Welcome again to our radiology class. This is our second session and we are going to discuss on the pulmonary vascular diseases. Under the pulmonary vascular diseases, we have pulmonary edema, pulmonary hemorrhage or hemorrhagic edema of the lung, pulmonary embolism, pulmonary arterial hypertension. For a start, we're going to discuss on pulmonary edema. Pulmonary edema happens when the rate of fluid accumulation in the interstitium exceeds the lymphatic drainage capabilities of the lung. First, the fluid is stored in the interstitium and then it overflows and then go to the alveoli. For the differential on pulmonary edema, differential diagnosis, we have pneumonia, hemorrhage, neoplasm, and alveolar proteinosis. So I have to remind you again, class, that your clinical history and physical examinations are very important in order to arrive at a diagnosis. Ancillary studies are only used to support your diagnosis because most of the diseases will not have a pathognomonic appearance and thus they will all look the same, but when based on the history we can arrive at the proper diagnosis. The radiographic findings of pulmonary edema will include thickening of the interstitium. This results in loss of definition of the intrapulmonary vascular shadows, peribronchial coughing, and tram tracking. Ground glass opacities are seen in the peripheral and subpleural interstitial structures, such as your curly A lines, your curly B lines, and curly C lines. Curly A lines represent thickening of the central connective tissue septa, while the curly B lines are those in the peripheral interlobular septa, while the curly C lines are a network of thickened interlobular septa. Your interlobar fissures will also be thickened because of fluid. If treatment is successful, then these findings will resolve within 12 to 24 hours. We have different causes of pulmonary venous hypertension and pulmonary edema, and this may be due to obstruction to left ventricular outflow, left ventricular failure, mitral valve disease, left ventricular myxoma, chortrea striatum, obstruction of pulmonary veins, and obstruction of intrapulmonary veins. Your pulmonary edema may be also due to increased permeability of the vascular structures resulting from septicemia, shock, major surgery, burns, acute pancreatitis, disseminated intravascular coagulation, drugs, inhalation of noxious fumes, aspiration of fluid, fat embolism, and amniotic fluid embolism. So this is a picture of your pulmonary edema, your early state of your interstitial edema. Here on the picture in the right side, you can see the short transverse linear densities in the periphery. These are the curly B lines. As discussed earlier, the curly A lines are interstitial and the curly C lines are interlobar thickening. So to best understand the picture, we have here a comparison of the normal chest X-ray on the left side. So another example of your pulmonary edema, the one on the left shows linear densities in the inner to mid-lung zones of the lungs, and then the picture on the right side shows the typical bat wing or the butterfly configuration, which we also discussed in the previous lecture. The next of the pulmonary vascular diseases will be pulmonary hemorrhage. This is difficult to differentiate from pulmonary edema or pneumonia. Thus, again, I will repeat, your clinical history and your physical examination are very important in order to arrive at the diagnosis. Here in pulmonary hemorrhage, there is rapid development of airspace opacities associated with dropping of hematocrit and with the patient presenting with hemoptysis. So this could be caused spontaneously. This could be due to trauma, which is most common. And then we have embolic disease, vasculitis from infection or autoimmune disease, and drugs. Associated renal disease, hematuria, collagen vascular disease, or systemic vasculitis can also be seen with pulmonary hemorrhage. Absence of fever or purulent sputum and findings of normal or elevated carbon monoxide diffusing capacity are ways to differentiate pulmonary hemorrhage from pneumonia. The presence of hemosiderin-laden macrophages in sputum, bronchoalveolar lavage fluid, or tissue specimens are evidences of chronic or recurrent intrapulmonary hemorrhage. So, to show you examples of pulmonary hemorrhage, we have here in the picture on the right side, confluent and patchy densities here in the right upper lobe, which represents pulmonary hemorrhage. This could be a patient with previous trauma. So the picture on the left side shows isolated densities on the left side and confluent and patchy densities on the right side, representing pulmonary hemorrhage. Next, we have pulmonary embolism. Patients with pulmonary embolism presents with dyspnea, pleuritic chest pain, coughing, and anxiety. Tachypnea, rales, and prominent pulmonary component of the second heart sound can be seen. Your D-dimer level can be elevated, but this is not specific for pulmonary embolism. Deep vein thrombosis is usually found, so you must do compression and Doppler ultrasound of the legs or CT or MRI venography. On chest X-ray, you can see localized peripheral oligemia with or without distended proximal vessels, which we call the Westermarck sign. And then you can also have peripheral airspace opacification or linear atelectasis. If you already have pulmonary infarction, there could be minimal pleural effusion and pleural-based wedge-shaped opacity, or what we call the Hampton hump in the lateral or posterior CP sulcus, and there is no air bronchogram. To diagnose pulmonary embolism, you can request for ventilation or perfusion scanning, which uses macroaggregates of albumin radiolabeled with technetium. On CT angiography, there will be intraluminal filling defects or non-opacified vessels with convex filling towards the proximal lumen with peripheral oligemia, pleural-based wedge-shaped consolidation due to peripheral hemorrhage or infarct, linear atelectasis, and pleural effusion. Pulmonary angiography will show intraluminal filling defect or the trailing end of an occluding thrombus outlined by contrast. There could also be prolonged arterial phase, diminished peripheral perfusion, and delay in venous phase. Pulmonary embolism can also be due to non-thrombotic lesions such as air, which could be iatrogenic, fat due to long bone fracture, methacrylate embolizations complicating vertebroplasty, and from radioactive seed implant embolization. Your malignancies can also cause tumor emboli. So, example of pulmonary embolism on chest X-ray, you can see prominence of the right descending pulmonary artery. You have greater diameter of the right pulmonary artery as compared to the left pulmonary artery. And then here we see the Hampton's hump. You have a density at the right base, and on CT angiogram you can see the filling defect pointed by the arrow at the left pulmonary artery. The last topic will be pulmonary arterial hypertension. This happens when systolic pressure in the pulmonary artery exceeds 30 millimeters mercury. On chest X-ray, there will be enlarged main and hilar pulmonary arteries that taper rapidly towards the lung periphery. There could also be enlargement of the right ventricle. Pulmonary arterial hypertension can be caused by pulmonary venous hypertension, left heart disease, obstruction of pulmonary venous return, lung disease or chronic hypoxemia, pulmonary arterial disease, primary pulmonary hypertension, pulmonary vasculitis, HIV infection, drugs, and chronic pulmonary thromboembolic disease. For our last slide, I will show you an example of the pulmonary arterial hypertension. You can see on the slides on the left side labeled right pulmonary artery and the main pulmonary artery, which are dilated. So on the picture on the right side, you can see a CT scan of a patient with a dilated main pulmonary artery and the dilated left descending pulmonary artery. I hope that you have learned from these slides, and I hope that you will retain what you have seen and prepare for the post-test. Thank you so much for listening.